Unshelling Medicine Podcast. Healthcare in the language we understand.
So ask questions, especially with that breastfeeding analogy. You know, your breast is not separate from your body. The milk is coming from the circulation, and it has contact with the lymph and the blood and everything that's flowing within you. So there's form of a sense of diffusion and things just getting mixed up. So your baby is getting whatever is flowing within you. So please, please, please ask questions, women. Talking about the phone ringing off the hook. How important is it for a doctor or doctor's office to be cooperative with a pharmacist or a dispensary of sort, especially when it comes to providing appropriate care to their patient, their common patient?
Well, I like to say it's the rule of thirds. So a third of the doctors are fabulous, a third of the doctors are sort of, and a third of the doctors are, we know their names, and when they call, we cringe. That's it. That's exactly how it goes. So it's the rule of thirds. And really, I get it. I also get it. Pharmacists will call about everything because we are legally obliged to. It is our role. Mm-hmm. So when a prescription comes in, the person who dispenses it and hands it to the patient, that's the pharmacist. And we are the ones legally responsible for that medication. So when we ask, questions of you, we're asking them to make sure that the drug is appropriate. We're not asking to pry, because our role is to make sure that the drug is appropriate for the condition. And prescriptions don't come with your condition. It doesn't say using this for diabetes, using this for weight loss, it doesn't come like that. So we don't know. We're blinded. We don't have that answer to why are you taking this. So you'll have a pharmacist ask. And so again, to your point, why you click yes is because you should know that that drug is for your sign or symptom or your disease state, that it actually matches and it works for that. So we as pharmacists need to know the indication, which means why. What's the reason for the medication? And does that fit? The other thing is, as pharmacists, when we speak to physicians, we sometimes will have to make sure that the dose is correct for that indication. So a lot of times we see in mental health situations where mental health diseases, sometimes psychiatrists will go outside of what we call the norm, right? The sort of normal dosages. And it's necessary in some situations. If someone is in a full panic, or if they're manic depressive and they're in a really deep state of depression, sometimes they'll get an increased dose, which is higher than the normal dose. So we'll call a physician and ask, is this appropriate? Because we as pharmacists want to have it documented that we did ask, that we know it's appropriate, that the doctor did intend for that dose, so that when we go to the patient, we can say, look, if you're going to look this up, the normal dose is 450 milligrams a day. The doctors put you on 600 milligrams, but it's for a short period of time. So that, you then need to come back down to the 450, or you're at 600 milligrams for the next 3 months, but not forever. We need to know this. So we'll call the physician about this. And a lot of times it can be as simple as a dose change. It can be an interaction that we found. It can be that your kidney function isn't good. And so this medication needs to be reduced based on your kidney function, because the standard dose is something like ciprofloxacin for antibiotic for urinary tract infections. In a normal person, you would take X dose. But if you have reduced kidney function, you'll take less. So we as pharmacists will figure all of this out behind the scenes. We'll speak to a physician and ask him for that dose change, or ask for clarification on that dose. Ask that, sometimes the allergies, we have the allergies, but, let's say the son took the mom and didn't know the allergies, and the doctor didn't have it recorded, or it didn't come up in their system. Sometimes when you go to the pharmacy, though, we have it. And so we'll say, oh no, this person's allergic to penicillin. And yes, there's a cross sensitivity to that antibiotic. So that's kind of why a pharmacist will speak to a physician. And we also advocate. So another thing is, the medication might be very expensive, but the doctors don't know what your insurance companies cover. We don't know until we put it in, right? We put it into the computer, it dials out, it tells us that it comes back and says, this is how much it is.
Right.
So physicians don't have an encyclopedia of how much insurance companies and what insurance companies pays for what. Could you imagine adding that to their plate? Pharmacists don't know it as soon as we look at your insurance. We have to put it through. They tell us. And there's coverages and maybe you have a deductible. So all these things come into play. So sometimes we'll call the physician and say, this is simply too expensive. Can we use another drug within that same class?
Right.
So in other words, saying we want Jello, just we want the green Jello. It's less expensive than the red one. Can we still do that? And the physician will say, sure, do it at this dose. So there's all these conversations that go on back and forth. And for the most part, I would say a lot of physicians welcome the pharmacist's phone call. They want them because they want to make sure the patient is safe.
Right.
And that's what our role is. Our role is to make sure that medications are taken only when required, when the benefit is higher than the risk, and when the patient can manage it, take it appropriately, understands how to take it, and we follow up with that. Does it work? When you come in for a refill, we'll ask, how are things going? That's why you want to say yes. You want to say to the pharmacist, I've been taking this for a month. It doesn't seem to be doing much, but I've got all these other side effects. And we might say, yes, it takes 4 to 6 weeks, 4 to 12 weeks before that medication really takes effect, right? So you don't stop it before it actually starts to work too. So all these things it's a communication piece that we have with physicians, with specialists, with family members, all of this combined. And I would say, sometimes we get phone calls from family members who want to know about their 18 or 21-year-old son or daughter. That's where it gets tough because as pharmacists, we can't disclose this. There's health information bylaws and acts that we can't just have a conversation with anyone about these things. They have to be part of the care team. So sometimes you have to bring legal documents in order for us to have that conversation with a loved one instead of you as the patient. If you're the caregiver, you need to have these documents. You need to bring them to the pharmacy. That needs to be recorded on file so that we know we have the ability. And if something gets changed, you also have to let the pharmacy know that person shouldn't be speaking on your behalf or coming to pick up your medications. Something as simple as that. When someone comes in and presents and says, I want to come and pick up your medication, you need to have some sort of communication with the pharmacist that says, yes, Lydia can come get your medications, right? So sometimes people find pharmacists to be difficult and we're being difficult in those ways because we're protecting privacy and we're protecting your health and we're being your advocate. So understanding where we're coming from is also that communication piece. Why is the pharmacist asking these questions? It's not because we're trying to become annoying. We're trying to help you. And so there's that fine balance between patient and pharmacist as well that needs to be explained. And oftentimes when I see patients in clinic and I'm prescribing, I'll say to them, does this plan seem okay? How do you feel about this? Is this okay for you? Or I'll say, I have to ask you a bunch of questions. If it's too much, we'll take it slower. But if you're okay with answering them, if something doesn't feel right, just let me know. I'll explain why I'm asking, So it's that process of really gaining the trust so that it works both ways. I need to trust that what you're telling me is true. You need to trust that what I'm asking has a reason for it.
Absolutely. Just to advocate for pharmacists, I think pharmacists catch a lot of fire and strays that are not really theirs to catch. Because if a doctor prescribes something and the pharmacist go to fill that medication and they find out there's an issue with insurance, right? And at this point, the patient is frustrated because my doctor prescribed it. I got a notification that you received a script. However, why are you not filling my medication? Why is it taking all this time? Why are you holding the line up? Another aspect of that is shortage. You mentioned ADHD medication. There was a time that ADHD medication was hard to come by. And the pharmacy got the brunt of that aggression. It wasn't just the only mental health medication that was, there was all of a sudden the shortage at a time where people were losing their minds the most, right? The pharmacists received the brunt of that frustration. They have nothing to do with the production line. They have nothing to do with the pharmaceuticals themselves. But however, because this was their line of business, the frustration was directed at them. So be nice to your local pharmacist. So the other part of, prescribing medication before we go into geriatric population is, you talked about if the medication is appropriate for the diagnosis. How do you justify, what is that process like justifying a medication that is used for an off-label use of a medication? Like, say, since Ozempic came up, let's use Ozempic, for instance, or other GLP medications that are mostly geared and directed at, diabetics. For somebody that is using it for weight loss and to justify that, how would the pharmacy go about that off-label use justification? It's the first that comes to mind, a lot of medication on the market like that.
Well, what we kind of look at is evidence-based use then. So the way that it works in the sense of like, why is something indicated for a certain drug? What is the reason? That's what the FDA or, Health Canada or wherever in the world, that's where the regulatory body looks at the medication and approves it for those reasons, because that's how it was tested.
Right.
Then what happens is it gets put out into the mass public where millions, if not billions of people then start to use it. And we notice certain things work for it. So when we talked about, we'll just use the example of Ozempic, we started to seeing that patients that have PCOS, the polycystic ovarian syndrome, we look at that and say, oh, you know what? Now that's allowing them to become fertile. So maybe for some of those patients, we'll start using this. Well, that's not how the drug was studied. This drug was studied and has an indication. In other words, a reason for this drug is diabetic. So if you're diabetic, it's going to reduce blood sugars. But what we see in the masses is that it can also help for fertility in some of these women. So when a prescription comes in and the patient is not diabetic, doesn't have these issues per se, and wants to use this, now we know obviously Ozempic has helped with weight loss. So we say, yeah, we did know through the studies that it helped with weight loss, but the indication is not weight loss. The indication is for blood sugars. But when the physician writes a prescription and it's for this other indication, then really it's evidence-based. So is there enough studies to suggest that this works in that way? And that's where the pharmacist and the physician will write it for that, and the pharmacist will fill it for that reason and document that. So we do our documentation. That's why things take a long time, because we need to do all of this extra documentation and work. You talked about ADHD medication. Well, they're like controlled substances. We need to document if we're changing doses. We need to document if you're picking it up early. We need to get a physician's release. There's all these rules around narcotics as well. So a lot of the times when we're asking for the indication, it's because we need to make a documentation for it. Sometimes insurance companies will allow it for certain indications and not others. And they'll only follow what the manufacturer's indication is. They won't follow the other evidence-based. So sometimes that becomes a reason why we have to call the insurance company and say, look, this is evidence-based. We're using it for this reason. All the other medications haven't worked. This is the only medication that we're going to try now. And then we get what we call like a special authorization. So in other words, there's a special reason for it. So now it can be covered for you, even though it's considered off-label. And that's what we mean by that. It's not the indication that was set out. So if you go Google on any drug and you'll find the drug company's prescribing information, the prescribing information has the reason why that drug works or what it's for. And that's what that's all about. So we really look at that indication. And when we do that and we go off-label, we document. And that's why it takes a bit of time. But it doesn't mean we refuse it. It's just, weird things. Like if you're using a medication for a yeast infection, but yet you get an antibiotic, then we know that's completely wrong. That is not for that. This is more of there's an evidence base for it, but it might not be the drug manufacturer's reason for it.
Yeah. The yeast infection antibiotic analogy is like using sugar in your soup instead of salt. It just does not.
Exactly. Oh, that's so good. Yeah, that is so good. That's exactly it. Putting salt in your
coffee.
Coffee instead of sugar, right? Exactly that.
What?
Not
Who is
supposed to be.
doing that? Goodness gracious,
No,
we,
yeah,
we we have a lot to learn.
yeah.
Um, so I think what this highlights is, well, that's why I get very excited and often lend my expertise to when it comes to drug trials, clinical trials, and things of this nature. It's because the trials are very narrow. They're not broad and they're not diverse. That is why we're still having this, oh, it works for that. I didn't think to try it on this ethnic group. That is what is happening because we
Mm-hmm.
think of
Mm-hmm.
people as a monolith. And even within the people that have had or experienced atrocities when it comes to trials, right? We're still not doing enough to make people feel comfortable to be included in a clinical trial. Because if there's a diverse population of not only people, race, culture, but also diagnoses that are related. So if we think of sugar, okay, let's use, the GLP-1s. If we're thinking of sugar, there are a lot of disease processes that attach to sugar, right? Cancer is one,
Mm-hmm.
dementia is another,
Mm-hmm.
reproductive health is another. So if we at
Mm-hmm.
a clinical trial phase just say, okay, where is this pyramid that leads to all this diagnosis and chronic condition that is attached to sugar? All right, let's have a representative of man, woman, black, white, not just black and white, but American black, whatever African countries, because we are not a monolith again. Even with the indigenous tribe, we have the ice people and the desert people, the sand people, right? DNA makeup is not the same. Polynesians are very different.
That's right.
A Canadian is very different in the DNA makeup of a Russian, of somebody from England, right? Yes,
Mm-hmm.
migration happened.
Mm-hmm.
However, when it comes to your environment, your DNA does change and is conditioned, right? The people who migrated from, say, any African country and they've lived in the West for 10, 20, 15 years, okay? They're not going to have the same tolerance of things that they had growing up when they go back for a visit, right? So there's a different changes that happen within us. And I think the more we diversify clinical trial, the more we diversify and include people in a drug trial of any kind, the less we're going to have this oopsie, oh, it works for that. Oh my, I didn't know. Look at that.
Mm.
And also the drug manufacturers should also stay in trend when it comes to, when we find out through evidence-based practice that things work for other things, to also update their list.
Mm-hmm.
I worked for an insurer, several of them actually. And what you said is very true. An insurer is not going to go outside of what the manufacturer set as perimeter for that drug. They're not going to do that. So if you're a drug manufacturer, pharmaceutical, if you need to hire more people to do this, then that's fine. But the more we can get to having a healthier community environment and people, the better it's going to be for everybody. So if there's something discovered in evidence-based practice to be effective for whatever drug that you manufacture, that list of approved conditions should be widened, right? So that the insurance can feel comfortable in saying, okay, the manufacturer said it can be used for this and this and this. Okay, let's include that in the list. It will help everybody. I'm just saying. So geriatrics.
No, absolutely.
Go ahead.
No, you're 100% right. I think the evidence-based practice is where we see most of how the drug actually works.
Mm-hmm.
It's not just the clinical trials. The clinical trials is just one aspect of getting it to market. Once it gets to market, that's when we really understand what the drug can and can't do. And that's where then the information needs to be updated. Right. The insurance company shouldn't hold on to just that one diagnosis when we see that it's being used for all these other things and helping. It does need to change. It can't be just restricting, it to those things just to reduce the dollar, because it ends up costing the healthcare system in all the other aspects, and it costs the patient. The patient is the one that suffers, because then they can't have access to the drug without having to pay for it. And that's not fair to the patients who are paying for the insurance, or, the employers that are paying for the insurance. And, the systems that are publicly funded, they're paid by tax. There's no such thing as a free healthcare system. We're paying by taxes. So, we're still doing that. It's different access points, sure, but you're still paying. So I think it's really important that we look at the whole aspect of healthcare. It's not just us as patients who have to advocate. It's healthcare professionals that have to advocate against these companies, even just working environments, to make it safe too, and to make it accessible for everyone. I think that's a really good point that you raised. Really, really good point.
Thank you. I try. I know a few things, not a lot. So, it's like, getting it to market. The one equivalence that I can see with that is that going to school and actually practicing, because what you learn to school is very focused. That is the trial. Getting out and actually practicing and working, you gain more skills that way. Same thing, getting it to market and seeing what it's used for. That list should be updated pretty regularly, please. We need it. We all need it. All right. Geriatrics. So our loved ones, aged parents and aunties and uncles. This is a population that naturally things decline. Eyesight, cognition, coordination, memory sometimes. So what are the safeguards for anybody who's listening that has an elderly parent or a loved one that they're caring for when it comes to polypharmacy and medication safety?
Well, it's a loaded question, but really,
you can do
we
it.
know that, with patients that are 55 plus or chronic disease states, we know the medications increase, average 5 to 7 medications per day. So when we add those medications into the system, because you're right, things start to fail. We get achier. We have issues with our liver, our kidney, our cognition, our pancreas, or blood sugars change. So we start adding medications, our cholesterol, being our high blood pressure. We start to put things into place. Now, I'm going to say one thing. We have changed the age of death every time a new invention comes out with medications too. So medications are good and they're bad. So good when they work, bad when they don't. Good when they're followed properly and we take them appropriately, and harmful when they don't. And your analogy, as you've been doing, it's kind of like a snake venom, right? In the right dose, perfect. Too little, not good. Too much can harm. And that's the snake in the cup, right? It represents pharmacy, which is the drug. So it's really important to understand when you're on multiple medications that you have a reason for each drug, that it's not something that has been left on there for years and years and years because you were taking it when you first had this and then nobody reevaluated whether you need it. So when you talk about medication reconciliation, which is a huge aspect to looking at medications, we look at when we say that, what does that mean? We look at why are you taking this? Let's do the labs to make sure you still need to take this. And what's it causing for you? So we also see what we call a cascade of events in the sense of you start one medication, you have the side effect of constipation. So then we put you on a medication to help you go to the bathroom. Now you're on that medication. So now you're on 2 for one reason. And then you have something else happen. So now we notice that your bones aren't as dense. So we're going to put you on a medication for your bones. And now you have to take that in the morning, but that makes you a bit nauseous. Well, now we're going to give you an anti-nausea pill. So now we've got 4 for 2 reasons. So this cascade, this adding on and on and on, what we need to do there is really look at what are the signs and symptoms. Why did that medication get started? And is there other alternatives so that we can reduce that? So if you started a medication 10 years ago, when you're now taking it, there's other medications that potentially have become better, so less side effects and more what we call targeted to the body, more selective, more targeted to help, that can be changed. So there's a deprescribing and a reanalysis. Those are the 2 things that you should be getting anytime you have 4 or more medications. Why are you taking these medications? What are they for? How are they helping? What are the side effects? And can those side effects, if that's why you're taking another drug, can be changed some other way? Now, if you're taking a medication for pain and you have a situation where the pain medication is causing you constipation and nausea, likely you can't come off those medications because the pain medication is, let's say, for cancer, and you're going through that actively. You have pain. there's no shame in taking 3 medications because it has an indication and you can't change that. So now what you're trying to do is just make sure that those medications are working for you and you have a reason. And what I always say is, does the risk cause worse harm or is the benefit better? So that's what you really need to understand. Is the benefit greater than the risk?
Right.
And so if you have to be on 8 medications, but you can answer on every single one of those medications that the benefit is better than the risk, then you likely need to be on those 8 medications, because everybody's disease state is different. Everybody has different things that are going on. Everybody is going to have a unique set of conditions, and that might warrant a medication or not. We do know that a lot of these medications interact, and a lot of them, if they don't have a regular yearly medication review, that you don't need to be on them. And some of them can come off. Like the one that I see the most is really the PPIs. So the ones for increased acid. You start to have, stress or something happens, you get put on it. And then you'll see patients who are well into their 80s still on this medication that they started when they were 60 years old. And it's like, we need to probably look at that again. And it's a process to get off of these medications too. It doesn't just happen overnight. It's like building muscle. It's not going to happen, you lift a weight and tomorrow you look like Arnold Schwarzenegger. That's not going to happen. It's going to take time. So, and that might never happen in that way, right? But having said that, you need to understand it's a process. When you get on a medication, to get it right. And when you get off the medication, there's a process to that. You just don't stop drugs, because that can cause even worse problems, especially if you look at a medication like high blood pressure. We don't just stop something right away. Or if you look at a medication for, mental health reasons, we don't just stop, because it can cause rebound effects. So in other words, it's like a bouncing ball. You hit it and then it just comes right back up or down. So you got to make sure that when you're looking at medications, there's always a reason why. The benefit outweighs the risk. Those are the 2 rules to drugs that you should always look at. And don't just take something for the sake of, I want to try it. Doctor said I should, so I'll try it. No, understand your risk versus benefit and make that decision. So that's where the educate piece of ACE comes in. Really look at this medication, read about it, understand what it's going to do in your body, understand how you need to take it, what you can and can't take it with, how you're going to come off of the medication. Is it a lifelong drug? And I talk about this because of blood pressure and cholesterol medication. We know and see that a lot of people, and women too, we think about heart disease in men, but women over the age of 65, after menopause, heart disease is primary. It's really high. And so we look at, medications for blood pressure, and we have to look at medications for cholesterol. These often are lifelong drugs. We take them for the rest of our lives once we start them. And it's not something that we can easily come off of. We look at cholesterol medication now a little differently. Like when you're at the age of 80 plus, we don't see that there's always a huge benefit, but that depends again on the person. Is it a cholesterol that is, medication in the sense of, is it you were put on it because of your eating? Is there other things that you can do to reduce your cholesterol? Or is it because of family history? So there's some things that we can change and some things that we can't. But we know that prevention is always key. Even if you have these disease states like high blood pressure, to protect your heart, going for a walk. I'm not talking about running a marathon, but go for a walk, increasing your walks, increasing your ability to be social with people. We know that social connectivity reduces issues with our disease states. So there's little things that we can do. Social isolation in seniors is like smoking, 15 packs of cigarettes. So, of course that's unhealthy. Being isolated, trying to then break that so that we don't have to rely on medications, because again, that's a preventative measure when we're getting older.
See, I knew you could do it. That was great. So if your loved one, just be on the P's and Q's. Everything declines with age and metabolism, the body processes things differently. So something that was prescribed at 60 may be too strong at 80. right? Just that medication reconciliation is really a thing. And what we mean by that is that take inventory of every single thing the person takes in the name of medication. So prescribed therapy, over-the-counter therapy, herbal remedies, all of those things, even herbs, right? So ginger is really great with GI stuff, right? Does this person take, ginger supplement? Do they use ginger in your food a lot? Even chili, cayenne pepper, the hot stuff is really good for circulation. Also, things that people don't think is that serious are usually very insidious. I had a scary but funny moment one time, and I'm talking about teas. There was a patient that had antibiotics IV infusion at home, and we went out to do an IV infusion, and I saw her 2 days prior. This was like a Monday, Wednesday, Friday kind of infusion. I saw her 2 days prior, and the protocol was to draw blood first, so we can check certain labs as, we continued therapy. And I did her venipuncture, got the blood, got everything, Vicodina, whole pressure, great, everythh was good. On this day, I went in, everything was prepped and ready to go. Tourniquet, access the vessel, Vicodina, all of that good stuff. I told her whole pressure, right? And while I was drawing the blood just seemed a little thin to me. If you're a medical professional and you've done this, you can tell the viscosity of the blood, which is like the thickness of it. It just was flowing a little too freely for me. I'm like, vial after vial. And after that, she held pressure while I took care of everything. I turned back around, to take it off. And what do you know? Blood everywhere. At this point, she's panicking. I'm panicking internally, but I have to keep cool. And I'm like, no, it's okay. What's going on? I'm like, okay, did anything change in the last 2 days? Medication changes? Are you stressed? We're going through this, like absolutely nothing changed. I haven't gone to my doctor. Nothing has happened. And, she's visibly upset. I'm kind of relaxing her. She takes her hand off again. And then, we're trying different methods to apply pressure. Now, I started with a question, what did you eat this morning? Nothing much. I just had toast and tea. Okay. What kind of, bread did you have? Regular brown bread. Okay. Roll out. Nothing there. You said you had tea. How much tea do you have? Oh, like my healthy big mug. You've sent it before, the big mug. I love to drink. Okay, great. What kind of tea did you drink? Hibiscus tea. Hibiscus is a blood thinner. So if you love your hibiscus tea and you're on blood thinners, don't do it, right? So if you're going in for surgery and you had a healthy serving of hibiscus tea, stay away from a few days before your surgery, right? So these are things that do happen that are very innocent practices that can have big ramification, right? And I told her never to do that to me again. And she never knew. Okay? She never knew. So know how your herbs affect your body. Know the function of each herb. Cardamom, turmeric, know the function. Know what they do, what metabolizing effect they have on your body. It's very, very important. And if you don't know, seek out that knowledge. We do our best here on this podcast to bring in professionals who are great at what they do to disseminate this information. So we're going to include all of Lydia's business, whatever way you can contact her. We'll also include smoke signals, for people still using smoke signals to contact people.
I might not see it. Yeah.
So
I think hitting the yes button. Hit the yes button. I'll do that.
Love it. We'll include all the information, educational materials, however you can reach out to work with her, whether you're an organization, a pharmaceutical, a hospital, an individual, whatever. Reach out to people that are actively educating and advocating both for the providers and the practitioners. She's one of those people, and I'm happy that I got to connect with her. Please let us know what you think about this episode. We'd love to hear from you. Should you want more episodes like this that talk about things that you may not have thought of but have an effect on your life, do let us know. We will be more than happy to have more of these. And any final thought for her listeners?
I just want to say the most important thing that you can do in healthcare is be your own active participant. That's really my message. And I think, you've 100% also with your stories confirmed that. And I think that's ultimately, if you don't know, ask, because it is your health. And it's really important that you do that to prevent errors.
Some people feel, I don't want to look stupid, ask. I'd rather you look stupid and be alive than try to be smart and dead.
There you go. Yeah, another great analogy of the importance of this.
Seriously.
Right.
A stupid alive you is better than a dead smart, fake smart you. Just ask. Right? You much rather ask that people willing to help you, that people willing to impart the knowledge and support you. Ask questions. No question is stupid. Well, ask questions, just understand that there's somebody on the other end of things. And for somebody that's willing to listen to you and answer your questions, please, be empathetic and be mindful that there's a human in, that casing you're talking to. And most importantly, do not hit that no button. Do you have any question for the pharmacist? Yes. Even if it's, I'm doing this, is that still good? Great. Okay, later. See you later.
Is this okay?
Yes, yeah. That's it.
Exactly. That's right. Just summarize what you're doing and get an okay. Yeah,
that's it.
You're right.
That's it. You're paying for it. Use it. All right? Great. Thank you, everybody. And thank you for being here. Yeah, we'll talk.
Thank you.
All right. Bye.
Thanks for tuning in to Unshelling Medicine Podcast. If you want to stay up to date with the latest episodes, make sure to hit that subscribe button on your favorite podcast platform. If you enjoyed today's episode, please take a moment to leave us a review. Follow us on social media at Altruistic Scribe on Instagram, TikTok, Facebook, YouTube, and LinkedIn. We share additional tips, updates, and health-related content that you won't want to miss. Have any questions or topics you'd like us to cover in future episodes? Reach out to us at altruisticscribeco.com. We're always eager to hear from our listeners and tackle the health topics that matter most to you. Until next time, stay healthy and take care.